Good afternoon, this is Renelson with the agency. We'll go on and get started. I want to thank everyone for joining us for our webinar today. We are recording this webinar, so we do ask that anyone who is on the phone, you mute your phones, and if we do start getting feedback, we will go on and mute you as well. We do have a chat box, as well as at the end of the meeting, we will open it up for questions from everybody. Or you can type questions in the chat box as we continue through. With that, we do want to, today's presentation is really focusing on some overview of some new primary care provider components of the ACHN program. We've been up and running for 2 years, and we want to kind of update some information about our quality bonuses, our cost effectiveness bonuses, and some other general operational issues. So with that, I will turn it over to Travis Hauser with our Managed Care Operations, and he's head of the Associate Director for the Provider Unit.
Thank you, Drew. Hello, providers. I'll go over the objective for my portion. First, we'll discuss the Supplemental Security Income, or SSI, migration. We'll discuss the Primary Care PCP Referrals update, the Body Mass BMI Requirement update, bonus payment updates, and the reserve funds, the fiscal year 2022 patient-centered medical home attestation, and the delivering healthcare, or DHCP, rate increase. The SSI migration. So as of you should already know, for the last few years, Medicaid has been slowly migrating into a new eligibility system. Effective August the 1st, we have started migrating the SSI recipients into the new eligibility system. That did go into effect on August the 1st, and because of that, SSI recipients were issued new Medicaid IDs starting with 530s. You should start using those new Medicaid IDs immediately. It is recommended that you ask those recipients during check-in for the new Medicaid IDs, particularly their new Medicaid ID cards. That way you will have those Medicaid IDs on record for future visits. For more information on the SSI migration, you may view the alert that's titled Notice of Issuance of New Medicaid ID to SSI Recipients, and that is the link on the PowerPoint slide here. The PCP Referrals update. Also effective August 1st of 2021, the PCP Referrals is no longer required to specialists. This means that any specialists such as your cardiologist, your anesthesiologist, certain DME providers will no longer require the PCP referral for reimbursement from Medicaid. Please keep in mind that recipients that are in a lock-in status will still be required to get a lock-in referral from their lock-in provider, and also prior authorizations will still be required. That process has not changed. Some providers still have policies in place to require referrals. In those instances, we ask that you clarify with the providers to make sure that they're not asking for a Medicaid provider, but instead they may just be asking for a general medical referral. The BMI Requirement update. Also effective August 1st, the BMI requirement has been reinstated. We did waive this requirement during the public health emergency for the following procedure codes that are listed on the screen. As of August the 1st, we will require that the BMI diagnosis be appended to the claim if you bill one of those procedure codes. One change that we did make previously, we required that the BMI be appended to all claims with the specified procedure codes. Effective August 1st, you'll only be required to report the BMI once per calendar year. And that BMI status can be confirmed on the recipient's eligibility verification screen. This slide just shows an example of where you can find the BMI status on the recipient's eligibility. It's similar to how you would verify the recipient's physician visits. If you look at the column that says the row that says BMI visits, if there's an indication of one or more in the paid column, that means the BMI has been taken for the year and is not required in order to get reimbursement. If there's a 0 in the paid column, then you will need to append a BMI to the claim in order to receive reimbursement. Other notes about the BMI requirement, in certain situations, unique situations such as if a recipient is in wheelchair bound or an amputee, we do have override procedures in place for those situations, and those procedures are outlined in the Provider Billing Manual, Chapter 40. There are certain provider types, such as endocrinologists or specialties, that are exempt from the BMI requirement. You can also access that list of provider types and specialties that are exempt from the BMI requirement in Chapter 40 of the Provider Billing Manual. Pregnant women are exempt from the BMI requirement. However, you must have a pregnancy diagnosis on the claim in order for the BMI requirement to be exempt. During the public health emergency, the telemedicine and telehealth option is still available to providers and recipients. In these situations, the BMI will still be required. We ask that providers use subjective information, such as asking the recipient for their height and weight to calculate the BMI, and you can use that information to append the BMI diagnosis on the claim. Also, make sure to document the BMI in the recipient's medical record. Next, we'll talk about the bonus payments and the bonus payment updates. The three particular ACHN bonus payments, the quality, cost effectiveness, and PCMH, are available to participating ACHN providers. Effective October the 1st, we will pay the quality bonus payment based on actual performance. We will use claims data from calendar year 2020, which is January the 1st, 2020 to December 31st of 2020, to calculate the fiscal year 2022 quarter 1 quality bonus payment. You must achieve at least half of the annual quality metrics to receive the quality bonus payment. And as always, we have the quality measure scorecards that are available quarterly in your web portal. The cost effectiveness bonus payment. I believe nobody be in this. Where do people be able to pick them up? The cost effectiveness bonus payment is based.
They're there.
Please, I do want to encourage everyone to please mute your phones if you're not speaking. Thank you.
Thank you. The cost effectiveness bonus payment went into effect on January the 1st of 2021, and it's calculated based on the attributed recipient. Sorry about that. The cost effectiveness bonus payment went into effect on January the 1st of 2021, and it's calculated based on the attributed recipient's risk scores and associated costs. You must meet or fall below the median threshold to qualify for the cost effectiveness bonus payment. And we do offer the cost effectiveness scorecard, and it is available quarterly in your secure web portal. The PCMH bonus payment is 5% of the annual ACHN bonus pool. It is based on annual attestation. You must be PCMH recognized as of September 30th of the previous fiscal year in order to qualify for the PCMH bonus payment. Attestation is due to the agency no later than October 1st annually. The next slide is just a visual representation of what I just went over. We'll start at the bottom For providers that are not interested in the ACHN and they do not wish to participate, you'll receive the basic fee-for-service reimbursement. You will receive the bump payment if you are enrolled in the bump program. For providers that are actively participating in the ACHN, that means you are an active Medicaid provider and you have signed a Medicaid agreement in addition to an agreement with at least one of the 7 ACHNs, and you're actively participating, you will be eligible to receive the 3 bonus payments if you meet those metrics, and you'll also be able to receive the participation rates. And again, those bonus payments are impacted by your attribution. So just make sure that you are seeing your recipients. The next slide is just a timeline of the bonus payment rollout. As I mentioned earlier, the quality bonus payment will start based on performance on October the 1st. We implemented the cost effectiveness performance on January the 1st of 2021. And then as of October 1st of 2020, we based PCMH off actual attestation. And to mention the quality bonus payment again, which is the next bonus payment that we'll calculate based off performance. Fiscal year 2022 quarter 1 quality bonus payment will be based on calendar year 2020 claims data. Again, that is January the 1st, 2020 through December 31st of 2020 claims data. The last bonus payment update that you'll probably be happy to hear is that we'll be releasing the ACHN reserve funds. Earlier in the year, we announced that we would reserve $100,000 from each quarter of the reserve funds payment. We began that process in quarter 2 of fiscal year 2021. As of today, we are scheduled to release those funds on your August 20th check write. So when you receive your remittance advice on this Friday, you'll be able to view the reserve fund payment for fiscal year 2021. We will continue to reserve funds for fiscal year 2022, and we will release those fiscal year 2022 funds in the quarter 4 of fiscal year 2022. The Patient Center Medical Home PCMH Attestation. The PCMH bonus payment is based on PCMH attestation for fiscal year 2022, and those are due to the agency no later than October 1st of 2021. I always encourage providers to go ahead and begin your PCMH recognition process as soon as possible because I understand it can be lengthy. So go ahead and start now to avoid potential delays. Attestation is required to the agency to be eligible for the 5% bonus payment. The attestation form is available on our Medicaid website at the following link that shows on the slide. The next topic we'll discuss is the DHCP rates. Effective October the 1st, maternity global rates will increase by $300. In addition to that increase, providers will also have an opportunity to gain an extra $50 on each of the DHCP bonus payments. That's the H1000 initial bonus payment and the G9357 postpartum bonus payment. If you meet those qualifications, which is seeing that recipient within the last 90 days of the menstrual period for the initial visit, and seeing the recipient between 21 and 56 days of the delivery for the postpartum visit, you'll be eligible to receive that $150 bonus payment. In total, that's a possible increase of $400. Nurse midwives will continue to be reimbursed at 80% of physician rates. And if you have any questions about billing, please reach out to your Gainwell provider representative. maternity rates are based on the location where your office is located. And so this here is a map of the rural and urban counties in Alabama. And this map is also available on our website. At this time, I will turn it over to Ms. Connie Fales and Courtney Hanson, who will discuss quality and the provider profiler updates.
Thank you, Travis. We will be sharing updates on how the agency is calculating chlamydia rates. We will talk about the quality measure bonus calculation methodology and the cost effectiveness bonus calculation. The big picture, Health and Human Services identify and publish core set measures annually, and CMS uses that data to better improve the quality of health care, help improve health care, provide a national system of measuring health care. So all states participate to some degree. At this time, it is voluntary, but it will become required in the next few years. At the end of the year, we will report our findings on health care outcomes for the previous year. We've been reporting on measures for almost 10 years now. During the creation of the ACHN program, we gathered measurement data from previous years to aid in determining appropriate benchmark targets and baselines, and those benchmarks and baselines are located on the agency website. The goal was to incorporate reachable health outcomes. To qualify for the bonus payment, PCP groups must achieve a quality score of 50% or higher. The next slide shows a list of child measures. Providers help to improve outcomes and by encouraging more well child visits and more adolescent well care visits. And also for that same population, improving immunization rates. And then on the next slide are the adult measures: antidepressant medication management, HbA1c testing, follow-up for emergency department visit for alcohol and other drug abuse or dependence, and chlamydia screening. So let me give you a little background about the chlamydia screening update. There was a discrepancy between the specification guidance and the agency policy. We were not meeting our goal, nor were we in the same performance range with other states like we are with all the other measures. So we did our research and determined that a particular code was not included in the HEDIS value set. 87801 is that code. So we have incorporated that code. And for our providers, for the Medicaid providers, that code is used more often than other CPT codes. The agency some years ago instructed providers to use that code when testing for more than one STI. Since CMS and the measurement steward removed that code at some point, it made Alabama's rates hit bottom, thus appearing as if Alabama was not doing enough screenings. We worked with an independent review organization, IPRO, and made the decision to include code 87801 when calculating this measure, and our rates have improved. Immunization data. The agency incorporates imprint data for the quality measures, for the immunization measures. We match our demographics data with the imprint registry data. There will be discrepancies that we can't avoid, but we do make every effort to gain all the data to determine that our recipients are indeed getting immunized at a reasonable rate. So, for example, how many ways can you spell O'Neill? Mary Kate, is it hyphenated? Is there a space? Is that the first name? Is that the first name and the last name, et cetera? So we make every attempt to capture the vaccination record by including variations of names to the best of our ability. And also approximately 50% of the immunization registry, approximately 50% of states use the immunization registry data for quality measure calculation. Adjustments to quality measures bonus calculation methodology. Beginning October 2021, the process for calculating quality measure bonus payments will be modified. Measures with less than 10% in the denominator will not be counted, so it can't count for you or against you. Before, there were no denominator limitations. And then, again, all of these measures have been validated, reviewed by an independent review organization, IPRO. So that is all I have. And then next we will hear from Courtney Hanson with UAT.
So just as a review for the guiding principles for cost effectiveness, this is consistent with the ACHN's principles of paying for activities with a focus on preventative care and health outcomes. The agency is acknowledging that the risk levels vary across practices. So these results are risk adjusted using validated national methodologies. The program is evaluating activities at the group level. So over the past year, we've made quite a few adjustments to the cost effectiveness methodology. So I just wanted to take a moment and review those. So the University of Alabama puts the claims data into the MARA software and then turns the risk scores over to the Medicaid agency. Previously, we used the top 7 diagnosis codes on each claim. We have since increased that number to 40 because we're trying to catch as many as possible. We acknowledge that most providers will be limited to 12 per the claims processing system, but the new limit of 40 accommodates certain inpatient claims and then preemptively allows for any policy adjustments that may come in the future. In the software inputs, we've also added the crossover claims. So these claims were previously excluded because they were claims that Medicaid was not paying for, and we were more concerned about the financial relationship. Using MARA risk scores in the ACHN means that we are now more focused on the clinical relationship, which is why we've added those claims back in so that we can capture the patient's acuity better. And then our last adjustment to the software inputs was to adjust inpatient claims. We've refined the process for both revenue codes and procedure codes regarding a stay at the inpatient. I also want to make note that the agency has removed inpatient psychiatry claims. This was a mutual effort between the agency and some of the providers that have these inpatient psychiatry patients. This is a prime example of the difference between the Alabama Medicaid's experience and claims processes and procedures and the calibration data set that Milliman used to develop the MARA risk scores. That's why the agency has made this decision, and this is a great example of what has guided decision-making in adjustments to the cost effectiveness process. And so just wanted to note that the agency is assessing different models to determine a maximum total cost or amount that could potentially be capped for cost effectiveness calculation purposes. And once finalized, the information will be shared with providers.
Thank you, Courtney and Connie. The last slide just shows program contacts for the Managed Care Operations Division and the Networks and Quality Assurance Division. You can also access the provider manual at Chapter 40 at the following link. And as always, the Medicaid website is an available resource. If you have any questions regarding the ACHN, any of the bonus payment questions or quality, please reach out to us at achn@medicaid.alabama.gov, and we'll provide an official response to your questions.
Thank you, Travis, Connie, and Courtney. We do have a couple questions that come in through the chat box. The first question is, are the quality bonus payments calculated as a group or per provider? A group. Yeah, those are calculated as a group at the group level, as the bonuses are also paid at a group level. That way, if a patient sees a couple of the providers within a group, that it does get counted for the whole group. The state approved a bill in May that must accept all children if they refuse to vaccinate. How will this affect our measure? Generally, we are aware of that bill. We have been talking with our provider associations regarding that. As of right now, for all of the vaccines, COVID vaccine is not included in the child or adolescent vaccine measure. So the COVID vaccine is not included in that. And we're sticking with the same practice that, the more patients that you see, if you have a couple patients that choose not to be fully vaccinated, or they just are not up on all of their vaccines, well, we would encourage you to work with those recipients to make sure that they stay up to schedule. But having one or two, if out of a larger population of patients, should not greatly affect your performance measures. Will we be able to print out the presentation after the meeting for reference? Yes, as well as we are also recording the meeting so that you can go back and view it later if you have any questions. All of the slides and the recording will be published to the ACHN's page on Medicaid. It's medicaid.alabama.gov. And at the top, you'll click ACHN, then click Providers, and then it will be under one of the presentations. What is the start date for the telehealth visits to include BMI?
August 1st. August 1st is when we reinstated the BMI requirement. We're still under a public health emergency, so the telehealth and telemedicine option is still available. We did reinstate the BMI requirement on August 1st, so if you do see any recipients August 1st and beyond via telemedicine, then you will need to append the BMI on the claim for the specified procedure codes.
Okay. Regarding the PCP and EPSDT referrals, I think a lot of providers are going to want the new referral form that will be updated as of 9/1/21. If a provider has an existing EPSDT referral on file, can you confirm that that referral is still valid and that they do not need a new updated referral form?
We'll have to reach out to the Medical Services Division with that question.
Okay. When the reserve is released, how will the distribution be calculated, based on percent of previous bonus distribution or per member?
Percent of previous bonus distribution, and it will be distributed per member level also, but the providers won't be seeing that member level information. They'll be seeing lump sum amount based on previous distribution, previous 3 quarters distribution.
Thank you, Kamara. You stated that referrals are no longer needed to specialists. I need clarification on that. How will this apply the 14 visit limit if the specialists do not file with an EPSDT follow-up with no referral? So basically, even though there's no need of referral for specialists, will that still count for the 14 visits? Correct.
Right.
If the child, the agency still encourages EPSDT checkups and follow-ups, and if there is a need or a diagnosis that's identified through the EPSDT screening, and that could lead to additional office visits, the agency still encourages you to do an EPSDT referral that would, for a child, which would remove the 14 office visits. That is something where you as a primary care provider have to be able to manage that. If it is just a child has broken their leg and they have to go to an orthopedic for a follow-up, but they don't, and they're generally a well-child visit, and they should not be needing more than 14 office visits for the year, you wouldn't necessarily need a referral for that orthopedic. What we're focusing more on is the EPSCT, and if that child does need more than 14 visits, we still encourage you to follow the EPSCT guidelines. Code 87801, how far back can this code be reported, and what is the diagnosis code used to report this code? So what's the diagnosis for that code, and how far back can they report it?
John will take this question. John.
Yeah, for the diagnosis code, that is STI screening. You can use several codes. Actually, you could even use 99 routine visit code. And the coding in the background will capture them all the way back ultimately, but for fiscal year 2020, that is already being calculated at this point.
So to clarify, basically, we have been seeing providers continue to use that code already, but because that code was not in the measure specs, we were not measuring based off of it. So, which is now, we have seen an increase in our performance and providers' performance because we have included that code, correct?
Correct.
Correct. So, I mean,
Yeah,
you don't have to go back and submit claims using that code. If you were using one of the other codes already, or if you have been using this code and your numbers have been down, that has now been adjusted.
That is correct. Yes, there was a policy, there's a AMA policy that's several years old that said if you were doing multiple STI screens at the same time, use the combination code, which is the 59801 code. So we just took that into consideration and adjusted our coding to capture that.
So what happens is, for the quality measure provider profilers, we used to basically base it on the chlamydia rates to generate the bonus payments. Since we are including this 87801, the rates have been tremendously improved with a lot of providers. That will reflect, that will make most of the providers, whoever is doing this STA test, counted for those STA, basically STA measure. Previously, Alabama's rate is 10%, and including this code made us to come up to 60%. So this will positively affect the provider bonus payments for most of the providers. I think that's all we have. Drew.
All right. The next question, quality measure, how can we report to Medicaid? All of our quality measures are calculated based off of the claims that you as a provider have submitted. So there's no additional information that you need to submit. Other insurance agencies do take hybrid information or chart information. They take supplemental information. The agency has chosen not to accept the hybrid methodology and report based solely off of administrative data, the claims data. So there is nothing additional that you will have to provide to the agency. Will our clinic targets for the quality measures remain the same? Yes, the agency for this past year have maintained the same targets. We will be reviewing the targets for the coming year in the next couple weeks. Can you please go over the measurement period for the quality payments? If you want to go back to that slide. Just a second as we get back to that slide real quick. Okay.
The quality bonus payment for the upcoming fiscal year, Q1, will be based off calendar year 2020 claims data, which is January the 1st, 2020 through December 31st of 2020.
Okay. Someone has a question if they could kind of give a high level what the lock-in referrals are.
Lock-in referrals are for recipients that are in lock-in. Those recipients are identified by our program integrity division, so those recipients know who they are. providers can verify lock-in recipients in the recipient's eligibility screen. And so if that recipient is in a lock-in, you will need to obtain a lock-in referral from that provider and indicate that on the claim when you file it.
All right. Let's see. The height and weight used to calculate the BMI can be subjectively reported by the patient for telehealth if the patient has no access to a scale. Is that correct? And that is correct. How do we get paid beyond the 14 visit limit?
We do not pay beyond the 14 visit limit. If that is the case, we encourage recipients to visit their local health department.
All right. Will there be a way in the future to submit additional diagnoses in excess of the 12 allowed for 8 outpatient visits? We will get back. I know we have researched that issue previously, and I believe we can take more diagnosed codes. I think the issue previously was a limitation of providers' claims processing systems, but we will answer that and post that answer as well after the webinar. If you have any additional questions, please feel free to add them to the chat box. Okay. Is the ACI quality measure based on the test or the level?
A1C.
A1C, okay. Yes, it is based off of the test, whether you tested, not whether we get the results, because generally we do not receive the results here at the agency. For the cost scorecard, the cost effectiveness scorecard, what timelines are being utilized for those dates?
Can we go back one more slide?
Okay.
And so for cost, this shows when we first started with the cost effectiveness bonus, but it shows that we use 12 months of data, but we offset it by 3 months so that we have those 3 months to collect all the claims. And so it's offset, but it's 12 months of data.
So it's a rolling 12 months minus the last 3 months. Okay,
yes.
Great.
Yes.
Okay. Are there any other additional questions that anyone has? Let's see, here we go. If we have previously provided a claim that didn't include the A1C data, but have found it was left off the claim, what is the best way to resubmit? All right, we'll have to get back to that one. Let's see. Got a couple comments in there about the appreciation, thanking us for the webinar and going over the minimums and cost effectiveness problems. If A1C was not billed on an original claim, is there a way to file to Medicaid for capture without getting duplicate claim? So basically the same type of question we have. We'll answer that. We'll have to go back and answer that after the webinar. All right. Any additional questions? If not, I do want to go back to that last slide. All right. I do have a good question coming in, and John, I'm probably going to need you on this one. For the childhood immunization and adolescent immunization, what does combo 2 and 3 include? What shots are in those combos?
John can share with you.
Yeah, John. Oh, I'm sorry, go ahead.
With the immunization, with the immunization vaccine, combination 2 is DTaP. I better let John do it. I'm not looking at my paperwork, sorry.
John, are you there still?
Yeah, so for the CIS, the child immunization, we're measuring combo 3, and that's the DTaP, the IPV, MMR, HIB, Hep B, VZV, and the PCV. So everything but Hep A, rotavirus, and flu.
Okay, and what is combo 3 for the adolescents?
So for combo 3 for the adolescents, that's going to be the meningococcal, the DTaP, and the HPV.
And it's combination 2 for the immunization and it's combo 3 for the childhood immunization and combo 2 for the adolescent immunization.
Okay. Could you please recap the no EPSDT requirement and Medicaid referral forms for specialty services?
The EPSDT requirement, that requirement has not changed. The only thing that changed is the PCP referral requirement. So if the service requires an EPSDT referral, you'll follow the exact same process that you normally would.
Okay. And what is the best report to show our current score of bonus? The last quarter, and then what's the next quarter scorecards are about to be released, correct?
The previous quarter scorecards were released in July. They're typically released after the bonus payments are released. The next bonus payment, besides the reserve funds, will be released in the second check right in October. So your next quality and cost effectiveness scorecards will be available towards the end of October.
There's a question, are the reserve bonus the same as last year? And we'll be using, yes, the bonus, the reserve fund actually will continue to use the same amounts. It was very beneficial for the agency. We didn't have to use all of it, but there was a few things where providers, we were able to merge clinics when they changed numbers and things like that, that really did benefit the agency. What is the difference between an EPSDT referral and a PCP referral?
EPSDT referrals are for recipients under the age of 21. There are some services that are required to have an EPSDT referral, like your therapies. And then I also recommend that you consult Appendix A of the Provider Billing Manual. That's the EPSDT chapter, and it will go in more detail of what the EPSDT services require referral.
There's another question about the bill, but I would encourage you, the agency does not have a copy of that. I would encourage you to go to your provider association. Is there an opportunity to send in information that may impact the 2020 data where we may have met the measure but not reported as such? No, that goes back to the agency's conversation earlier about the different methodologies to calculate measures. There's a hybrid as well as the administrative only. The agency has chosen to go administrative only, which means based off of your claims. The hybrid requires the agency to have additional staff to do chart extractions and additional reviews, which the agency just does not have the resources for. So we only calculate our measures based off of what it comes in on the claims data, minus the immunization registry, where we the immunization measures, where we also do pull in additional information from Imprint, the state's immunization registry. So far, all of these questions have been really good. We do appreciate all of your time. And again, I do want to remind everyone that we have recorded this webinar, and we will be posting answers to all the questions afterwards, as well as the slides to the presentation. Do we have any information posted that lists how you calculate each of the measures?
Yes, we can send the link to Medicaid.gov.
Okay. Yes, we do have information for those. We'll share as well on the with the webinar. All right. Well, thank you very much for all. We do have one question. Do the requirements for Medicaid referrals mean that the patient doesn't need a Medicaid referral, or that the referral can come from any provider?
It means that the patient does not need a Medicaid referral.
Okay, perfect. All right. Well, thank y'all all for your time, and we'll give you back 15 minutes of your day. Thank y'all very much.